Hey guys, what's up? I am going to be talking about taking some patients in the ER and how to manage your time well with them. So I'm going to pretend like you are getting a report from another nurse. You're just coming onto your shift and how to go through and make a plan with what you've received. So you do have, in this scenario, 3 patients, or 3 rooms, should I say. So the first patient the nurse is telling you is a chest painer. They have had chest pain for 2 hours, and they have a cardiac history, including stents and a myocardial infarction. They have had their labs drawn. They've had an EKG. Their EKG was normal sinus rhythm, and we are waiting on the results of the lab work as well as the chest x-ray. They had a chest x-ray. The chest x-ray is still resulting. So we're waiting on results for our chest pain patient, and that's going to start us off here. So chest pain is waiting on results. It sounds like everything's been done. Now this patient also has received some medications. They've received 4 milligrams of morphine. They've received their aspirin, 324 milligrams of chewable baby aspirin, and they did not get any nitro at the hospital because they received nitro en route. So while the EMS was bringing them in, they administered nitro to the patient. So waiting on results is basically what's happening with this patient. They're all packed up and ready to go. Vital signs have been stable. They're alert and oriented ×4. They're ambulatory. They did receive morphine. Their morphine was administered 10 minutes ago. So morphine IV, having it be 10 minutes ago, we'll have to reassess in 20 minutes. So the number one task right now that I want to write down for this, a task, is reassess pain. And the nurse tells us that the patient's pain was an 8 out of 10. So we need to reassess that pain in 20 minutes, and we need to check for results. Watch for blood work results, and also the chest x-ray. So the other patient that you have right now is a 40-year-old abdominal pain. It is a male. He said that he has been having irregular bowel movements lately. He had a long run of diarrhea for about 2 weeks, and then for the past week he has not had any sort of bowel movement whatsoever. He has a history of Crohn's and needs to have IV lab work, abdominal x-rays done. So he needs the whole packet still done. He's relatively new to the room. So the nurse came in, got the story, got vital signs. The vital signs are stable. Patient is in no distress at the time. So we need IV, we need blood work, abdominal x-rays, and then any sort of AXRs, any sort of pain medication for this patient. We will need to see if there's an order in for that or not. So under tasks, I'm going to write IV blood work, and then x-rays. You're going to need to get some abdominal x-rays done, and then pain meds. And then the nurse says the 3rd room is open, which I never find a comforting thing. I know people are like, yeah, woo, I have 2 patients instead of 3, but that leaves you open for an EMS or any sort of catastrophe to roll through and be placed in your room. So it always makes me nervous not knowing what's in there just yet. So I want to start off with the first thing that I do before I even start on these tasks is I go in and I introduce myself to my patients. I want to lay eyes on each and every one of them. I want to make sure that whatever that nurse who just left said is in fact true, and I want to do a quick assessment. So when I walk into the room, I'm like, hey, my name is Susan. I've just taken over as your nurse. Sounds like your plan of care, if I were going to the chest pain patient, sounds like your plan of care is that we are waiting on the results of your chest x-ray and your blood work. And I'm going to be checking in on your pain level. How's your pain level right now? And if they're like, oh, it's, a 2 out of 10, be like, great, I'm going to be back in about 20 minutes to check in on you again. And then I rerun their blood pressure and I grab a temp real quick and then I'm out the door. I have a full set of vitals because they have to be on a monitor. If you've got a chest pain patient, they're going to be on the monitor. So I validate those vitals and I'm out of there. That takes me about 5 minutes to do all of that, to introduce myself, to do those quick vitals, and then I'm out. Now, the next thing I would do is I would go in, I would say hi to the abdominal pain patient, and I would say, hey, my name is Susan. I'm just going to grab a quick set of vitals on you. I didn't see any pain medications ordered, and I know we need to get an IV and blood work on you. So what I'm going to do is I need to get your vitals, and as soon as I have an appropriate set of vitals, I'm going to go ask for some pain medications, and then come back in here with blood, IV and some stuff to get blood work, as well as some pain meds to give you through the IV if the doctor orders it. So I would then go step out. I would check in the charts, make sure that there really isn't anything ordered for sure. Double check your orders. I would peek at chest pain patient, see have they had any results back. They don't. Then I would go gather everything for the blood work. I would swing by the doctor's station. I would say, hey, do you guys, are you okay with giving my abdominal pain some pain meds? They are saying that they have a 9 out of 10 pain. I'll write that, 9 out of 10 pain in their abdomen. And let's say the doctor's like, yeah, sure, go ahead and give them some morphine. I already saw the patient. We need to get their abdominal x-rays taken care of. Sounds like they've had a history of Crohn's disease, and so they're probably just having a flare-up. Okay, cool. So I've already got my blood work and IV tools gathered. I'm going to run into the med room, grab the pain meds that they ordered, and I'm going to go back into my abdominal pain room. I'm going to start an IV, grab blood work, give them their pain medication. Note the time, because in 30 minutes I will need to be coming back for a pain reassessment. Now, these are the tasks that need to be done. Checking results, that's lowish on the list. So I put that at the bottom of my plan list. So check results, lowish. I put reassessing pain fairly high on my list. So I know that it was only 10 minutes in, but the patient did rate their pain as a 2 out of 10 after 10 minutes of having the morphine. And I would make sure to chart that reassess pain, put that pretty high. And we already did that, so that's great. And then I would also still come back in at the 20-minute further mark, so it's 30 minutes total, and just be like, hey, just checking in, your pain's still a 2 out of 10, and they're like, oh yeah, hey, thanks, or no, it's not, got worse. So you will want to reassess that. That's probably a high priority for me. Getting this IV and blood work done though, on this patient, that really helps get that patient rolling through the ER, gets their plan of care moving in the best way possible. So IV blood work, pretty high up there on my plan list. And if at all possible, I would get this delegated out to someone if there's somebody who is available. I never delegate my initial set of vitals and introducing myself to my patients. That's not something I ever delegate. I always introduce myself in person and I take my own set of vitals to begin with. So after you've given the blood work and everything, then you want to call down, be like, hey, can we get an appointment for an abdominal x-ray? If at all possible. But all of a sudden, while you are going in to give them their pain meds for your abdominal pain, you have somebody rolling into your open room. This is a lady who looks pretty beat up. She has a giant hematoma on her left eye, and EMS brings her into the room. So the first thing that you do is you get a set of vitals while they're telling you the story. The story is that she fell. She does in fact take Coumadin, and she is complaining of some pain on her face, although she has not been able to give you a number because she is only oriented to person. Very confused, unable to tell you if there was any loss of consciousness. Her husband, who came along with them, he's saying she's normally knows all of these questions, or knows the answers to all of these questions. This isn't right. This isn't how she normally is. She normally knows where she's at and what happened, but now she doesn't know these things. So he's all very panicked, and you want to make sure that he knows that, you're taking care of her, and include him in the plan of care, because he clearly is well informed about her care in general, making sure that you find out, hey, what meds is she on? What kind of history is she on? How much Coumadin does she take? When was the last time she took the Coumadin? Things like that, because the patient isn't going to be able to answer those questions for you. So we get that fall in here, and having them hit their head plus being on Coumadin, this now takes priority. We need to get this patient to the CT scan. So all of this takes a back seat. Our plan has readjusted, and this is what I like to call roll with the punches. Literally, you need to change your plan of care because it's no longer the important thing. So we are going to do IV and blood work on this patient as soon as possible, but I'm calling CT. I'm going to delegate that IV blood work and vital signs. I'm going to call CT and get that CT table cleared because I need this patient down. I need to find out if their brain is okay. So we're checking for brain bleeds right now. And then also because they hit their face, you're going to be checking for fractures of the orbital area. Once this patient has come back from their CT, you are going to reassess your plan again. So perhaps it's now past the 30-minute mark. You missed your reassessment of pain on that patient. I would poke my head in and reassess real quick. I would also let them know, hey, just so you know, I haven't looked for your results in the past few minutes, but I am going to, and I'll be back in as soon as I let you know if there has been anything resulted. So put eyes on that chest pain patient, reassess their pain real quick. Once the patient gets back from CT and you've done that, you want to administer that pain meds because pain is pretty important. Administer that morphine to your abdominal pain patient. They won't be pleased that they had to wait a little bit for it, but the CT took precedence over this pain meds. Somebody once told me, I think I was studying for the NCLEX, that pain never killed you. But other things can, so that's why pain isn't always like the number one most important thing, but it is really important to the patient, and it is important physiologically to the body that you aren't stressed out and in pain for too terribly long, because then everything else starts going haywire. So I still rate that as pretty high, but not higher than getting that CT for the patient. So I'd give that morphine, and I would call for their x-rays while I'm giving them the morphine. And I would note the time so that I can come back and reassess. And then I would come back in and do a full workup on this patient. While I am doing my assessment, I'm checking in on everything. Hey, have we gotten an EKG in this patient? Have any of their, blood work results come back? I would also be checking on my chest pain patient while I'm standing in that room. I would check to see, hey, has this patient gotten their results yet? If so, I might send a little page to my doctor, or I might swing by and be like, hey, have you seen the results for this patient? And then on my way out, after I've fully assessed my my fall patient, I will poke my head and be like, oh, hey, by the way, chest pain guy, you have some results back. The doctor's going to take a peek at them, and then they're going to come talk to you. So your x-ray came back and your lab work came back. If you see, now I'm just saying I am doing an assessment here on my CT patient. On my fall patient. I've taken that patient to CT, they've come back, I'm doing an assessment on them, and I've peeked at the results. If this patient has a positive troponin, I'm going to roll with the punches again. This patient has now become my number one priority. Okay. I'm going to call for help. Obviously, I need someone to do an EKG in this patient. So I'm going to be calling, hey, I need an EKG in this patient. I'm going to lay eyes on that patient yet again. I want to make sure that I am reassessing them. I'm going to check on their pain. Hey, has your pain in your chest changed at all? Is numbness and tingling anything different? Lightheadedness, shortness of breath, anything along those lines. And then I'm going to anticipate that this patient's going to be getting some heparin, because they have a positive troponin and a cardiac history. They're likely having what we call a non-STEMI. So these are pretty heavy patients, but your priorities continuously change throughout your shift. So we had originally, and I'm going to go back to my other screen here. We originally had this abdominal pain person come in, and they needed all of this stuff done. And so that seemed to be our priority at first. Okay, we need IV blood work. We need abdominal x-rays. We need pain meds. We need all of these different things on this abdominal pain patient. But then we had a fall come in, and boy, a fall with positive Coumadin on board, that takes precedence. And then all of a sudden we get results on our chest pain, and our chest painer is actually having non-STEMI myocardial infarction. And so you become concerned with that. You need to get an EKG. And this person, now the chest painer becomes your priority. You need to get that EKG. You need to anticipate that you're going to be getting heparin ordered for that patient and getting everything set up, the pump, make sure coags have been sent, things like that. So lots going on. You definitely change your plan as you go throughout your day. What seems important and what needs to be done at one moment can definitely change for the next. But that's how I would go through and manage my time with my 3 patients if that was the situation. So I hope that helped.